Continuing education credits for physicians and other healthcare professionals are provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information. The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed in this podcast are solely of those of the hosts.
Welcome back to the Cribsiders. I'm Chris the Chi-Man Chu, and I'm joined tonight by my co-host, Dr. Sam Mazer.
Hey.
And we're here for a live recording at the Association of Med-Peds Physicians, aka AMP, at the 2026 National Conference. So I have our guest tonight, Dr. Omega Ukamura, here to discuss transitions of care, transitioning patients from pediatric to adult medicine. But first, Sam, do you want to remind us about the show?
I would love to. So we are the Pediatric Medicine Podcast. We interview leading experts in the field to bring clinical pearls, practice-changing knowledge, and answering lingering questions about core topics in pediatric medicine. So tonight at this conference, we have a fantastic conversation with our guest, Dr. Okamura. She is a professor of internal medicine, pediatrics, and health policy at UCSF. She is a health services researcher and primary care physician. She is medical director for pediatric to adult transitions at UCSF Health, director of the resident research training program at UCSF, and the director of the clinical and translational sciences research pathway for the UCSF pediatric residency program. She's also the scientific co-chair of the Healthcare Transition Research Consortium, and today she teaches us about planning, executing, and overcoming barriers in transitioning kids from their pediatric providers to adult teams.
I'm amped for this transition to the
there
rest
you
of our
go,
show.
Chris. Well done. Well done. All right, let's do it.
So Dr. Okamura, thanks for coming on the show.
No, thanks for having me. Really excited.
So first, before we're an informal group, is it okay if we go by your first name?
Yeah, please.
All right, Maggie, so can you tell our listeners a little bit about yourself?
Sure. I am obviously a med-peds trained doctor. It's interesting in terms of my journey. I thought I was going to be a general internist. And in fact, I did my first rotation in pediatrics. I knew that you couldn't honor your first rotation. So I thought, there's no way I'm going to pediatrics. Just babies and poo and all this other stuff. And I was really interested in internal medicine because I love multi-system organ failure. And then I did my first peds rotation. And whoa, did I see a lot of complex medical conditions. And I loved it. And so obviously there's a lot of medical complexity, all the endocrinopathies out there. Newborn ICU, just abandon all pathophysiology, that we normally study. And, coming out of medical school, I was like, oh no, what do? I love internal medicine. I love pediatrics. And I wasn't, and I love just the medical complexity and the fellowship type stuff. So luckily I had a med peds colleague, and she's like, well, you don't have to choose. Do med peds. I was like, great, awesome. That's what I'm going to do. So that journey led me over to, I did my residency at Yale. And from there, I was thinking I was going to go into medical oncology and such, but then, I think I took care of like a 50-year-old cystic fibrosis patient in pediatrics, and then they were having chest pain, and trying to find the EKG without a reverse lead was difficult. So then I was like, wait, this is a problem. And then I kept hearing stories like, no, adult medicine doesn't want to take care of me. I'm like, what are you talking about? I talked to my internal medicine colleagues. This is not right. And, I started getting angry. Wow, this system is just messed up. We just couldn't give good, this navigation and care and the survivorship was just increasing. We were getting more and more of these adults who are kind of medically homeless in terms of their subspecialty care. And then one of my mentors was Michael Farrell, who is now at the University of Wisconsin, I think. And he's like, well, Maggie, you don't have to, it looks like you want to change a system, but you're not equipped to deal with it. You should do the RWJ Clinical Scholars Program. So I'm like, okay, I was pissed off. I was like, I got to do something. So then I did my RWJ fellowship, and I really focused on, well, is it really that bad? Is it just me and my old institution? And so I did my first study looking at adults hospitalized in children's hospitals. Like, that's not just me. I was like, wow, there's a 90-year-old that just got admitted to a children's hospital, like in this data set. All right, so this is an issue. So then my work then started really focusing on how do you improve systems of care? for individuals with childhood onset chronic diseases. After my fellowship, I moved over to UCSF. As part of that, I also did a fellowship in health policy to think, because it's not just about giving good clinical care, but how do you enact changes both on a system level, state, federal policy level in order to improve the care and the lives of all of our patients, right? Really thinking about that life course. And so driven by that continual, I'm just constantly angry about how our system is kind of like where I am today.
Awesome. That's an amazing story.
Yeah. I mean, I want to jump into the case right now, but just because we're so ready to go, but just because we want to get to know you even a little bit more, I thought I'd just ask you one more question, if that's okay. So we often ask this to all of our guests. What's the best advice you ever received as a learner, maybe as a teacher or any time in your career?
I mean, I already kind of focus on the fact that following your passion, because that will drive you. But the other thing I think I found early on is I would wait for someone to tell me what to do, in following that passion. Well, maybe you should do this. And my division chief once said, you had these great ideas. So assuming it's legal, right? And that you're doing it from a good place, just do it. And he's like, just do it. Don't ask for permission, ask for forgiveness. Yeah. And so again, make sure it's legal. It's all above board. Maybe you talk to a mentor, but if it's the right thing to do, I think you just pursue it and, just pave that
See where
trail.
It takes you.
Yeah.
Awesome.
See where it takes you.
Amazing. I'm going to start actually jumping into the first case here because we got a lot to talk about. We only got a short hour here. So let's see what you think here.
Hey Cribsiders listeners. On episode 135, we sat down with Dr. Tristan Nichols and talked about how AI is already changing how we practice pediatric medicine. From expanding differentials on tough cases to generating discharge instructions that family can actually understand, one thing that really struck me is the idea that AI shouldn't replace our clinical reasoning. It should support it. And that's exactly why I've been using Claude. Claude is the AI for minds that don't stop at good enough. It's the collaborator that actually understands your entire workflow and thinks with you. Whether you're debugging code at midnight or strategizing your next business move, Claude extends your thinking to tackle the problems that matter. What I love about using Claude is its deep research capability. It goes way beyond a basic web search. I'm talking comprehensive analysis with proper citations, pulling connections across dozens of sources that I would never have spotted on my own. It's like having a research partner who never gets tired. Whether it's working through a tricky inpatient diagnosis, reviewing the latest management guidelines, or putting together a teaching topic for my residents, Claude helped me think deeper instead of just skimming the surface. So Cribsiders listeners, for problems worth solving, get started with Claude at claude.ai/Cribsiders. That's claude.ai/Cribsiders, and check out Claude Pro, which includes access to all the features we mentioned today in this episode. That's claude.ai/Cribsiders.
So this is Tristan, 17-year-old male. This is a story, actually, I apologize, from Cashlak Children's. This is our wonderful children's hospital where we take care of patients here. So Tristan, 17-year-old male with a history of Angelman syndrome, complicated by epilepsy, dysphagia, status post G2 placement, global developmental delay, OSA, and abnormal gait with wheelchair dependence, who's presenting to Cashlak Children's for his annual well child check. You've been the family's pediatrician for years and even took care of Tristan's two older siblings who didn't have any complex medical conditions. The family members have, the family remembers how quickly the older two siblings moved on to their adult providers. And they start the visit by jokingly saying, so you'll be seeing Tristan until he's 35, right? And as you smile and shake your head, we want to start off with some basic questions about transition of care from pediatric to adult providers. So the first part is, what do you think makes up a successful transition to adult care?
Yeah, no, it's an excellent question because I think, and I want to start this off because I always have to define that transition and transfer are two separate things. That transitioning is a lifelong process. It doesn't end at the transfer. So transfer event may happen to some people, may not for others. Some people may never need to transfer different providers. So if you're in family practice, for example, and maybe you're followed by an allergist who's dual boarded, you're not going to transfer care per se, but you will need to transition your roles, right? And so I think of the continuous, you think of Bloom's thing about transition is this gradual acquisition of skills, knowledge, and as to best of your ability, self-management, understanding that people with developmental disabilities, for example, will have to rise to whatever what they are able to do with support from caregivers or their team, but understanding that it is a gradual process. And again, that continuation happens. That acquisition still happens even if you may go to a completely adult focused team.
Let's actually probably start with the beginning, because of course there's usually a transitioning planning stage that's occurring before the actual transition. And again, transfer and transition being separately, but just in talking in this comment here. So when do you think should parents, patients, their families, when should they think about transitioning to adult healthcare provider?
Sure. Again, thinking about, I'm going to go into that in just a bit. Going back onto the sort of the transition planning, I always joke that we have a Denver for developmental milestones, but we don't have an equivalent for self-management skills. How do we do it? And so that process of, making sure that people are ready, because sometimes when you are saying you're going to, hi, now you're going to a different provider, parents are not set up necessarily, because it's now it feels like abandonment. So, it's interesting because we talk about when to introduce, right? Because you're talking about transfer again, but that is just one part of transitioning. So some people will say, no, when you're born, especially for those with chronic diseases, like the genetic disorders, you start at birth. Other people are like, no, we're going to introduce something right before, like a year before, for transfer. But if you only focus on the transfer, you left out that 17 years worth of preparation. Why do I say this? So when we did our program for cystic fibrosis, we decided to start at 8. We're going to introduce transitioning at 8 years of age. And we developed this little handout, little check boxes, and we were pre-testing. And I handed it to a dad, and he looked through it and he started to cry. And I went, oh, crap. I used a different word in my brain. And I'm like, what did I do? Was it a different color? Did I say something inflammatory? And he looked and he was like, my child's going to live? I'm like, oh my God, not only is she going to live, you're going to have to worry about sex, drugs, rock and roll. You're going to worry about the girlfriend coming in and make sure you wear a condom. So what was really interesting is that the parent just wasn't even prepared to even think about the later stages and that kind of preparation. And then when we started introducing it to the 17, 18, 19-year-olds who didn't have that curriculum beforehand, they're like, what, I have to leave? I'm going to get abandoned. So it was a completely different mindset as to the issue of transferring. Whereas for the 8-year-old, it becomes normal. It's like graduating from high school. We don't tell high school students going through, it's like, hey, we never introduced college. And then at, senior year, hey, what are you going to do for college? And like, what? There's testing, there's all this other stuff you have to prepare for. Similarly to transferring to adult care, it's, thinking about this is just a natural process and this can be expected. And then, knowing that it's not complete after 21.
So one question I have is, you're talking about how you're sort of doing this introduction and you have this sort of framework. Is there any are there any of these frameworks that are published out there that a lot of people can follow that are easy to have access to these tools?
And so actually widely used is the Got Transition website. Many of you are already well aware of. They have these 6 core elements that talk about, they have little patient handouts for providers as well. They have all kinds of tools depending on your needs, introductory guides that you can give to patients, from policy to readiness to discussions. I think American College of Physicians also has something on their website for transitioning. So there's a lot of tools that are out there and differing checklists. But again, Got Transition is a great start. And you can go through and they have multiple links to go ahead and, for whatever purposes that you have.
And what framework do you kind of use to transition a patient, right? We talked about planning initially. We're going to talk about transfer at some point. What else goes into these frameworks, or at least the framework that you'll use the most commonly?
So, every system is different. And I think there are some health systems that use the 6 core elements, extensively, which is, doing the policy generation, assessing the readiness, all the way to ensuring integration into the system. I would say that my approach is relatively blended depending on the need of the patient. So for full disclosure, I practice in a general internal medicine practice, and I take on patients on the flip side, right? So I work with my pediatric colleagues in general pediatrics or around, and then I help integrate them into the adult healthcare setting. In that practice, right? So we're talking about care integration. There's many different models of care that are out there. You talk about like shared care model systems, transfer, direct transfer just ped only to adult. And, again, for my practice, I tend to do more of a blended model. Initial assessments. So again, my pediatric colleagues, some of the subspecialties will go through like the track or track equivalent, and every clinic has their own specialty, in terms of transition preparation. And then again, I rely on my pediatric subspecialty colleagues to kind of just introduce the concept and make sure that we think about it. Where I get more involved is that when a patient is about ready for transfer, we have a pretty good discussion about the psychosocial. So again, thinking about the biopsychosocial model of that patient. Where are they? Where is that parent? Where are they in their trajectory in terms of like their subspecialty needs? Do they need social work? I take care of when they land in internal medicine, and then helping them slowly navigate the adult subspecialty components, which can be its own pitfall.
Right. So it sounds like there's not really a one size fits all in the sense that everyone comes from a different level of care. And we've learned even some of that stuff from earlier today. But in general, there's the planning, the piece that goes into it, we have to transfer. And then there's an integration component into adult medicine that also is going to be a new piece that I think a lot of our pediatricians who may be listening to this show are learning about as well as we talk about.
And it takes years. It's not a one-off. You don't expect everything. Many people are transferring everything at once, like because there's cutoffs, the cliff, right? Certain children's hospitals are like, this is it. Bye. You can't see anybody. You're just cut off. And so what we're really trying to do, I think, as a field is, that gradual planning, have a runway, the safeguards of getting in. Sometimes, our general medicine practice was closed for 2 years at one point because of shortages. So, thinking really strategically about when does a transfer happen and who. So for us, we've really promoted primary care transfer, because we can't expect our pediatric subspecialists to know the nuances of adult subspecialty. So, for us, we're pretty complicated here at UCSF. We're a quaternary care center. So from a peds neuro department, that's fairly, it's, you have a singular clinic. We have 13 separate clinics for neurology. Do they go to movement disorders? Do they go to neurorecover? Do they go to stroke? Do they go to epilepsy? We have a really complicated adult subspecialty system. And so, navigating that. Just a couple weeks ago, there was a patient who had ACE, the antegrade, colonic infusion. And so I wrote to what I thought was just GI motility. Hey, I have this patient who has ACE. And she's like, well, I take care of upper motility. That's really lower motility. That's with so-and-so. I'm like, oh, we have a lower motility specialist. Okay. Do I expect my peds GI, friends to know that? The answer is no, right? These are the things that I feel like that, me as a adult, internist, but anyway, that is my role, right? To help navigate that very complex internal medicine system.
So I think this is actually a good transition to this case. So let's go through how many providers that Tristan is being followed by, and then try to figure out what we're going to do next. So Tristan here, 17-year-old, currently followed by general pediatrics, neurology, gastroenterology, and not specifying upper or lower, but psychiatry, PM&R, and pulmonology. So as the pediatrician, and this is the general pediatrician, should that person be responsible for coordinating transitions in each of these specialties, or solely the transition to the adult primary care provider?
Yeah. Ideally, it's a collaboration between both, because for the pediatrician, I think it's really hard to case manage each individual transfer and success. I always advocate that for the year, and again, it depends if you're in contact with that general internist. Having a transfer summary is really critical. For pediatricians out there, I can't tell you how many times like, oh, Maggie, you'll take the patient? Great. And I get nothing. I want a plan. Just tell me what you just told the family. So when I first introduce myself, like the first meeting is just like, hi, what's your favorite color? And what do you like to do for fun? Welcome. We're not that scary. Here, meet the front staff. And having a plan that I don't make changes immediately, right? The goal is let's carry out what you understood and let me work with you. And so then I go back with the pediatrician. It's like, hey, so if that person was in my system, I would say, okay, well, for GI, for like the G-tube, primary care takes over the G-tube care in our system. We have adult nutrition and general medicine. We take care of all the G-tube stuff, IR. So it's not a peds GI. So in our peds system, it's through pediatric GI. In our adult system, it's through primary care. So you don't do a GI referral. That would lead to a rejection and then parents will get upset, right? So again, that's where knowledge of the system is really critical. So having that pairing, because again, the adult primary care person knows all their subspecialties, right? And then depending on how that goes, and again, depending on the need of the patient, sometimes it's like, I'll take care of everything. Don't worry about it. Hey, this sounds great. This is my plan. Saw what you had. And sometimes the pediatrician will initiate some of the transfer. But again, sometimes people have a different trajectory in subspecialty care and how long they're going to stay. So between the 18 to 21 period, it's when I'll take on a new primary care patient. And then that allows a nice off-ramp or on-ramp into adult subspecialty care. And then it's that collaborative, otherwise being left in the lurch, for individuals.
So it sounds like the pediatrician definitely needs to discuss with the adult internist. The adult internist can at least point out, by the way, how we're going to carry this subspecialty. Hey, I can take over this, so you don't necessarily need that. But there should at least be a nice transition document we're hoping for. Some almost like a discharge summary from the hospital that says a discharge summary from pediatrics to internal medicine to at least provide some sort of, hey, this is what we've been doing and what our conversation with the family.
Yeah, and I think that it was interesting. We did a survey of our general medicine crew, and I asked how many of you, for those of you who took a new patient for pediatrics, got a discharge, a transfer summary, and it was like 5%. Yeah. Right. I mean, it was awful, and so. It's sort of setting up that your general internal medicine or family practice provider, setting them up for failure, right? Because I'd like to know, so, even just, especially for people with developmental disabilities, how much can they really understand function? So I don't go in assuming something. Whether, I've had patients where I was like, oh, actually, they can't understand anything too. No, they may be nonverbal, but they understand everything that you say. And you can't necessarily tell that in a room. So it's really getting everyone set up well so that family feels, they are understood, and also that communication, so they're not just being abandoned, right? That feeling of abandonment is really real for many of the families. And also that, hey, you as an adult provider care enough that you've met with or have discussed with my pediatrician, and okay, this is great. I feel that, I can trust this interaction.
And so this happens to me all the time. What do you do when and you were kind of mentioning this already, but kind of expand this thought. What do you do when different specialties hold on to their patients until different ages? In the sense that you were saying, hey, you got this kid at 19, but Palm will see him till then. Say they're a mitochondrial kid who'll follow him to 35. Like, what do you do, as you navigate that component?
Yeah, it's interesting because earlier in my career, I'd be like, no, there should be hard stops and blah, blah, blah. It doesn't work that way, right? It's just, I joke that this is where the bamboo, I just have a little inner bamboo motif, right? You just swing with it. Don't let them break you, right? And there's this humility too. So every subspecialty practice is different, and the pressures of why they can take a patient at a different time may differ based on your institution. Sometimes it's not because they don't want to, it's because their capacity is lower. So they push that off later. So for me, every patient that walks into my clinic is different. So some patients will transfer adult care earlier, and we're kind of ready. So I sort of have my go-tos in my system. And also it's kind of like matchmaking because, there's enough, we have fantastic clinicians. And, they have different personalities. So it's like, how do I match, the different personality styles? So I do feel a little bit of a yenta, a medical yenta, right? Of getting people into the right, location and just, again, making sure that they land correctly. And yes, some people will see up to age 26. Some people will see longer. If it's really prolonged, sometimes I'll just have this little ping to the pediatrics specialist going, so when do you want to transfer? Just asking. The other thing I did find is for people who are most resistant, once they made their first or second transfer, the parents are like, okay, I'm ready to go to adult care. It's all good. Right. And then we accelerate. So really meeting the patient for where they're at and just negotiating each one. I mean, many of my patients, like this one, will have 5 or 6 subspecialists. It's overwhelming. It's like, could you imagine speed dating with like 6 people? That's just terrible. So doing it, even every 6 months or something really helps. And I will say that for someone this complex, I'll meet them every, 3 months and just kind of go through their plan to get them integrated into the system.
I've definitely had some of those like congenital cardiology, or patients with congenital cardiology diagnoses. They're following their cardiologists into their late 40s and 50s, or admitting them still to the pediatric hospitals. So, I want to step back and ask, just to set the stage a little bit. So, what do you view are the differences between like the adult healthcare model compared to a pediatric healthcare model? And then we're going to get to each of those barriers afterwards.
Yeah, I mean, I think fundamentally in pediatrics, we have a very, it's very family-centered growth trajectory, and that you're trying to ensure that the child is fulfilling their life, right? It's they can self-actualize, that they can live in their community fully like any other kid. They are a kid, they're going to grow. And that mindset translates into everything we do, right? Staying at home, normalizing care. In the adult setting, and we're getting better, right? That it's more patient-centered. We focus very much less on the family, much more on the patient. And we focus a lot more on the disease, right? Because we're thinking, people who enter into internal medicine are often in their 40s and 50s. We don't really see a lot of young adults. They tend to be quote unquote healthy. And this is where we're talking about transitioning. These are 18, 19, they're still going off to college or getting a life, starting a family, doing what adolescents, doing the dumb things you're supposed to do, right? And so when we mix those two, sometimes families are sort of like, wait, they're not talking to me anymore. And also, and it's, again, thinking about for patients who need more support, so when they're hospitalized, families aren't able to be in the rooms necessarily with them. It's encouraged in pediatrics. It's not necessary, that's the case in the adult world. And I would say to the detriment. We had child life in pediatrics. Shouldn't we all have adult life in the adult wards? Right? If you're hospitalized, that's kind of traumatic for any person. But we don't, that focus on the person gets a little bit more lost. And again, our health systems are getting better, in terms of that framework. I think the medicine side is pretty solid. It's really about how do we treat our patients, right? How do we include them? What level of inclusion? And I think those are the things that we sort of kind of prep for, but we can also build a better system too, right? Like we did a pilot for adult life at one point. We got a masseuse into the adult wards, right? I mean, this is good, right? As an adult, if any of you have ever been admitted to the hospital, you kind of want to be treated like you would be in peds, right? There's nothing age dependent about just being treated like a human.
You've brought up many different barriers already, and I just want to be able to parse them out so that we're hearing them again, we're clarifying each. So, I want to talk about the biggest barriers to transition. First, at the patient level, can you talk about that a little bit?
Sure. I mean, there are papers. I mean, I could talk a whole hour about patient level barriers, right? And our colleagues from the rural sites, went in very clearly about things that are just, the geography. We're a quaternary care center. We take care of people from all over Northern California, insurance, transportation, family, equity, right? So what I mean by that is if you're a monolingual, non-English speaker navigating a really complex system, it is almost impossible. So and also just your health literacy and level of advocacy, right? So on the patient side, how much family involvement do you have? How much, again, developmental, status of that patient. So but I would argue that even if you're going off to an Ivy League college, you can't navigate the system very well either. So that level of just preparedness, did they go through any kind of preparedness of handling a healthcare system? I mean, sure, they took calculus, but they didn't know how to manage like our call center,
Yeah.
which I argue is harder to navigate than probably a triple integral. So, these are things that are oftentimes all the socioeconomic issues that come up in patients are potential barriers.
What about at the provider level?
Provider level, sure, a lot of people will say, well, the knowledge of the disease process can be a barrier. And I would argue that, as general internists, we get weird things all the time that spring up. I feel like the medicine part isn't, I wish it was just the medicine part, right? I think that the biggest barriers have been time, the social supports that we can provide for families. So, again, when we did our survey for general internal medicine, it wasn't the medical management wasn't the issue. It was about how much time we could spend to families, the case management and social work support that oftentimes the families needed. Maybe the training and sort of just young adult, the resources that are specific to young adults. Right? Because again, we focus a lot like on diabetes and heart, just other things or cancers. But young adults have a different sort of, at least in California, we have like different funding structures. We have regional center, et cetera, that adult providers may not be necessarily as aware of. And so having some of that support. But a lot of, if you think about it, again, it's all the support so that that patient can live their life with the conditions that they have. Right, those are the barriers that I see oftentimes in the provider end, and so DME, right? Pharmacy, PA, all the prior authorizations, the wheelchair, right, for this patient that we're talking about in the case. I'm lucky; I have a DME coordinator, I have a farm tech, and I have a home health coordinator in my practice, so I can manage a patient like this fairly easily. I mean, I have to great, shout out to our Division of General Medicine that has put those efforts into taking care of individuals with disabilities. And in a private practice, they may have all these, things available. And that's a marked barrier for many providers.
Hey, Cribsiders listeners, whether this is your first episode or if you've been with us since day one, you know our goal has always been to share real wisdom about practicing medicine. So let's talk about something that actually changed my day-to-day as a hospitalist, and that's FIG scrubs. I can't walk into a clinic or hospital without seeing people in FIG scrubs, and I get it, I wear them too. They're incredibly soft, form-fitting, and durable, and it's not just dust. If you've been watching a certain popular ER drama on TV, yep, they're in FIGs too. These scrubs get it. That's what drew me in and what keeps me coming back. And because we work with kids and kids come with messes, I love that FIGs are antimicrobial. When stuff gets on your scrubs, and it will, you just wash them and they come out wrinkle-free. I've washed mine well over 50 times and they still look brand new. All of that and so much more is why we've teamed up with FIGs. Now, Cribsiders listeners can get 15% off. Just go to wearfigs.com and use code FIGSRX. That's wearfigs.com and use code FIGSRX for 15% off.
You bring up a lot of different parts of the health system which are fully integrated with the provider level issues. Any other health system barriers that we see?
Yeah, I mean, I think that, every system, so here we're a hospital within hospital system. So peds and adult is integrated. Now, even with that, we're pretty siloed, right? So, the communication and ensuring that we, knowledge of how to refer individuals, finding a primary care provider, finding the specialty care, that navigation service, where we are one system. It really shouldn't be a barrier, but it still is. This is harder for the freestanding programs, right? So if you're a freestanding children's hospital, especially like in our rural communities, for example, then trying to find an adult program, right, to collaborate with, how do you have that integration, and finding those. I mean, I'm going to shout out to Dr. Burke, who's at Valley Children's, who's working with all sorts of medical centers, and such to collaborate and transfer patients, and really ideally transition them with eventual transfer, to the adult programs that are out there. So, again, it's that conduit of knowledge. I mean, sure, we can try to have parents, have medical histories, but these are 17 years worth of surgeries or medical conditions. How do you, again, going back to that medical transfer and that transition, summary, to the adult provider, having all that data and stuff transferred and making sure that you have the continuity of care.
What about other things like other social determinants of health? What type of barriers are we going to see here? Obviously, I mean, inherently there are barriers.
Yeah, I mean, for me, I feel like in my practice, it's ensuring that every family knows about the social services and the different opportunities that they have. And sometimes families they come up, I'm just upset. I can't get this, or I can't get home health, right? And so I spend a lot of time going, okay, well, these are, your rights as a patient. Let me tell you about a regional center system. Do you know about this? Oh, this is the one who will pay for this service. Oh, well, your lift is not paid for by Medicaid, but this system will pay for this. So I end up being kind of a social worker in order to go ahead and care for these, individuals. I will refer patients to our local family voices, right? To work with parent advocates. At the end of the day, parents have to advocate a lot, especially for those with disabilities, on making sure they know what the system can, because the system is not going to offer the menu, right? They're not going to say, oh, here's are all the services we'll pay for. Wouldn't you like this? It works on the ask model. And families don't know how to ask. So I feel like it's our job to offer that menu and figure out, what services they actually need.
And I was just going to kind of take that back to the pediatric mindset, for example. So, you're in pediatrics, your hospital system is set up a little bit different to have extra of these supports. Whoever chose to pay for them, created the clinic this way. How can you as the pediatrician set up the family for these expectations that this ain't going to exist the same way in adult medicine? Or it sounds like what you're telling me is that you have to ask for it. So maybe giving them the opportunity to ask, what can we do as the pediatrician side? This is a lot of good recommendations from the adult side. I'm curious.
Yeah, so there are handouts. I will say that we had a kind of a roadmap for our family voices that sort of started around age 12. It's kind of a roadmap of all the things that you need to consider. And this is more for special needs, from the IEP, right? To medical transfer was part of it. But before that, it's like SSI determination. It's your redetermination at 19 for Medicaid, for example. It is working with Department of Rehab. Again, this is going to vary from state to state, but these children are aging out of different programs, and having that roadmap early on to say, this is what to expect. Here are the hard stops. Here's a checklist. And what do I need to do to encounter that? So as a pediatrician, having that there is oftentimes really helpful for families. Again, especially if your child is going to need SSDI in the future, for example, having those things in place, or if they have an IEP, for example, it's really important to have that laid out.
That was like literally a perfect transition, because I actually was going to ask you about some of the legal pieces that come along with this. So let's actually start from the medical insurance perspective, because we all got to work through that, and then we can talk about some more legal stuff. So it sounds like getting this roadmap right off the bat is the smart thing to do. There are going to be certain timelines and dates that you need to pay attention to. We talked earlier today about differences between transitioning being greater than 18, but less than 26, and then over 26 and things like that. But can you kind of walk us through how should we be able to help our patients transition from a medical insurance perspective, and what do they need to pay attention to?
Sure. So one of the biggest gaps happens at 19 during Medicaid redetermination. And again, every state's going to be different in how helpful your Medicaid office is going to be with you. Some places have case managers, others do not. Every system has like a Title V program. And so what I have to do is let you determine in your state. But just knowing that 19, that's a big time of loss. For those who are on private plans, they can stay on their parents' insurance at, up until 26. Many of you will have to fill out a form, just to say, hey, they have a disability or they're a dependent and they need to stay on. And again, for pediatricians, hopefully this will not be an issue at 26, but after 26, if you have severe disability, you can continue on a parent's private insurance with medical determination. So I fill those forms out before they turn 27, or actually 26, so that they can stay on a parent's insurance past age 26.
Gotcha. That actually surprisingly sounds a little bit more straightforward than I expected. So that is good. There's like, okay, this is the date, you got to fill out the form to be on that. What we noticed, and this is more for the patients like Tristan here, who might be have some developmental delay, et cetera, long-term disability. What about legal guardianship, things like that? When it comes to decision makings, as we go from a legal perspective, the parents obviously still want to be involved in this care as they move, as they transfer their care to adult medicine. But now all of a sudden they need legal pieces behind it. How can you help them with that?
Yeah,
what do you recommend?
and as many of you know, it's very expensive to go through. In California, it's conservatorship, guardianship. In other states, it's thousands of dollars, to set that up. And many of our families can't afford it. So in the state of California, we have supported decision making that has become in law. So you can do a supported decision-making plan that's legally binding. I think that again, if the patient is profoundly disabled, then medical, guardianship or conservatorship is the way to go. And again, the biggest barrier I feel is cost. Everyone, some people will have pro bono help. This is again working with your local family agencies, because many lawyers will donate time for families in order to do this, especially through the courts. Supported decision making does allow for, if again, depending on the level of self-advocacy the patient has, they can say, oh, I need help in the medical realm, financial, or parents will get that right. They can sign off on it. And then that way you don't have to go to court. That can be legally binding and that can be put into the medical record. And then there's this other part for, even if you're not that, you don't have any cognitive disability, but you have significant medical issues, then there's, what level is that parent going to need? So again, people, I think, at least in our EMR, I think age 12 or 14, parents start to lose access, right? Because of the adolescent rights. So then you can sign, the patient can sign a form to say, no, I want my parents involved. And so again, it's a shared decision-making process. So the parent, the patient still we try to get them to advocate for themselves, but the parents are heavily involved in their care. And the same thing goes with those who are 19 and above. And it's not that different than adults, right? Because how many spouses do I have for my patients, right? Who are there because they are together on my chart, or that's our medical record system, because they do a kind of a shared thing together. So I kind of treat it like that. Not to say that, the person is married, but they are still relying heavily on the parent to help them with their care. And I just honor where that patient is at in terms of how they want their medical care delivered. And then, just the risk benefit of having somebody else involved into their charting and stuff.
And I'm kind of thinking again from pediatric perspective, is there a time when families would accidentally lose legal access essentially to their child? That because if we didn't explain to them that this is going to happen, that they need to fill out some of these forms while they're transferring care, are they going to have, all of a sudden they're going to lose medical decision making or something along those lines?
Yeah, absolutely. They have to know. I mean, sometimes the parents are like, I just lost my MyChart access, and it's just abrupt. They weren't notified. So it really is up to the pediatrician to say, hey, but in whatever system that you're in, my chart's or your electronic medical record ability and access will be diminished. And by 19, or 18, your child is a legal adult. So they have to sign off. Yes, it may be your insurance, but they need to give permission for you. No more than they can look at your medical record. The same thing goes, for your child, and just setting them up. And then it can be do you want to share or not? And that usually is when you have the patient by themselves in the room saying, how much, support do you want? Do you want it complete, separate or not? At that time, they are a legal adult. So therefore, you had that conversation, and that's negotiated per patient.
I want to ask a specific scenario which we all come across, and we've had this whole discussion: best laid plans, long runway, but things still happen. So one specific example is, what if the patient comes to you and they're mid-transition or hasn't transitioned, they've lost their pediatric specialty provider? How do you manage refills? Like, it's going to take a while to get into their adult provider. It just didn't happen the way you wanted it to.
I just refill it. I mean, if it's a methotrexate or something, I'm like, they can't go without. I mean, then it's the subspecialty note. What did they have? Okay, let's get you in. Let's put the referral in to the adult subspecialist. And, as long as it's not something that really needs a lot of changing, if it does, then it's a rapid fire phone call, right, to your subspecialty, subspecialist of choice with, myriad. Thank you. I'm so sorry. Would you like a box of chocolates? Whatever works to just help that patient go through, right? There are many who just get lost. It's like, what? You need insulin? Oh, my endo finally just cut me off. Like, no, they didn't cut you off. Just, all right. Here, okay, I refilled your insulin and we're going to go ahead and get this done, right? So sometimes it takes some coaxing. It's sort of a developmental milestone for them.
I think it's important to give empowerment to us as the primary care provider to be able to do that, because this is for the benefit of the patient, right? And this is been the plan. This is sort of establishing those things. So I think empowering providers to do that, I think is important.
And just out of curiosity, which provider are you calling as the pediatrician who's like still maybe having to refer this? Or if the other way around, are you calling an adult provider and being like, hey, you need to pick this up like now? Or are you calling the pediatric subspecialist that supposedly signed off on this kid, but you're like, hey, I really need you to help me out here?
So for some of the patients who were transferred off and they were given multiple warnings, sometimes going back for the medical management, I'll just say, hey, is it just safe for me? I may just loop back and then go back to say, is there an adult provider that you recommend? So that at least you give like a 6-month runway to get them into an adult subspecialty provider. And this is where I think primary care is an absolute bridge, talking about bridging, in terms of the subspecialty care. If they fall off, sometimes, again, it takes a while to get into adult subspecialty. But as a primary care provider, oftentimes, again, I am that conduit to subspecialty care. And that's, it's just supporting that patient. And it also, sometimes it's not even I'm not going to see you. What happens if the subspecialty provider just moves away? It's just no longer there anymore, right? The same thing kind of happens. And so we still have to adapt.
Yeah. And one of our benefits, I think, and I apologize, this is an academic medicine piece, and for not all our people and listeners and stuff like that are a part of academic medicine, but we are very good at navigating our own health system in some ways and can figure out, like, I've tried to reach the cardiologist's office by calling the main phone number, can't get in touch with anybody. I call 3 different people. I find a pool message that I know. I change admin gen peds to admin cards, and it goes like, and I know how to beat the system, and I know that my patients can't do that for sure. And I often know even people who came, for example, from a private practice who were calling into the adult academic medical center, they were private general pediatrician, like they don't even know how to get into that. So that is that's part of our job, is to be that conduit.
And I think that's where, again, having a friend, one buddy that you can find in your system that's on the adult side, that you can share a patient, say, hey, can I tap you so that you can help me navigate the adult system? And then that way it just allows, because it is at the end of the day, sort of a person to person level. It's the relationships. We forget you're not as a specialty, you're not just a referral in the system. You're this human being who wants to do well for your patient. And so those humanistic interactions is critical for that, oh, darn it, oh, crap moment when someone lands on your door and you really need quick access and curbsides to get that patient into care.
And I also, we've been talking a lot about the medical side and us prescribing medicines, refilling medicines. A lot of these patients, especially those with medical complexity, have a lot of ancillary services that they use. I was curious about helping transition from that perspective. So how can we help patients through transitioning their physical therapist, maybe their wheelchair assessments? Do they have a wheelchair clinic versus a different thing, a DME program in adult medicine, speech and language pathology, occupational therapy, any of those ancillary services? How do those kind of go down?
And again, this goes back to that system is really complicated and it's highly variable from location to location. So depending on where you are and what system you work in, finding that adult providers, like how do you normally get a wheelchair assessment? Who do you get to do it? Will be sort of in your back file because that allows you to think, oh, once they age out, this is what you're going to go to. California is kind of interesting because we have California Children's Services, which is our Title V program. Yeah. Many times their transfer planning is, let's get all the DME equipment ordered now so that you're good for the next 7 years, right? So there's this sort of rush to get everything placed. And then you move on to your adult program, but you have all your DME. That can be messy because sometimes they order the wrong standard and then it's, I had one patient who transferred, but they turned 21 and they aged out of CCS. CCS ordered the wrong equipment. It was adult, but the patient was like 40 pounds. So needed child, but then CCS had ended. So I had to work with all the DME vendors to get a pediatric version. But for me in the adult healthcare system, I could do that and just, luckily had a lot of help trying to call and just get it all fixed and return. But again, that's having that conduit, that one point person you can find to help navigate. Otherwise, again, our system is very different than, from other healthcare systems that are out there, but there's going to be some sort of parallel in being able to coordinate that stuff.
All right, so we're going to get to audience questions in a second. I want to ask one more question. So how do we define successful transition? Are there any measurable outcomes or other than the feelings like, yeah, we did pretty well?
That's a great question because even our Healthcare Transition Research Consortium is trying to figure that out. What is success? Some people have measured success as their disease outcomes, right? They look at things like death. I would argue that's the worst outcome. I mean, I'd like to abandon that one, right? Other people will use proxy measures, that are disease specific, like hemoglobin A1C, et cetera. But a lot of individuals, when you look at families and stuff, a lot of it is quality of life. Can they do what they want to, with the condition that they have? Is their disease management controlled such that they can pursue what they want to? And I feel like for transitioning, do they have their health care as managed as well as we can? And that they can pursue whatever they want in that, in their societal context. I think those are the most important things. I mean, at the end of the day, our patient, we have to align what they want to do in life. It's not just the healthcare, right? Their healthcare, hopefully, it's less than 5% of their, of their active, going into clinic and stuff like that. We're such a small component. They want to go, play video games or, hang out with their friends and go to movies and stuff like that, right? So is their condition interfering their ability just to be a whole person?
All right. Should we bring out audience questions?
Yeah, let's definitely do it.
If anyone has any questions.
Hey everyone, thank you so much. My name is Adi, I'm a medical student. Just a quick question. In your own experience, have you seen patients lost to follow-up or report medication non-compliance? And if so, how do you personally handle that situation?
Oh, absolutely. I mean, I think that's been a large driver in terms of the healthcare transition field, is that adolescence is normal, neurodevelopmental. kind of fruition doesn't happen till age 26, right? So I can always joke that, I don't know if I'm fully neurodevelopmentally finished yet either. And so rather, I'm not punitive. Really, at the end of the day, I mean, sometimes there's regret, but a lot of it is helping individuals. Like if they're coming to me, it means that they're at a point in their life that they want to manage their health or something happened. And so then it's working with the patient for where they're at. Sometimes I remember I was in acute care, and there's this like 19-year-old, and I was examining him, and it's like, oh, what's that big scar in your chest? And he's like, oh, I had heart surgery as a child, but I'm fixed. I'm like, oh, well, actually, and I found he had some, fairly extensive cardiac surgery. I was like, you actually need to follow in our congenital heart clinic. And so, again, like catching them early is great. Just not to say that it's bad, but it's like, I want to keep you healthy. And these are the things that we have to do. And then we work just, again, on what motivates the patient. Everyone's going to be different. And working them to get them to a regimen that will work with their lifestyle. And, again, these are people I'll meet with more frequently. And luckily we have telehealth too, because, if they don't show up to clinic, I can just, get them on their cell phone, and touch base with them, and then they can, go to their labs while in between work or, whatever in their life is a barrier to getting them into clinic. But I think the key is accepting the patient and working with them in a partnership. That's what we were trying to do.
Thank you so much. I'd love to hear what are the things that keep you up at night from this perspective when it comes to your patients, and what do you feel are the things that can be improved on the different levels, the patient, the provider, and the system base that would help you sleep better at night?
I think fundamentally our system is not great at supporting families and patients, especially for medical complexity. And it actually is more for disability rights, right? Of communication, treating the family, and ensuring everything is in place. I mean, right now I'm in this thread of a patient with medical complexity being discharged, and not all the discharge stuff came through. And they're just trying to push the patient out. That is not unique to transitioning, right? That's just part of being a patient in our system, but it really adversely affects our young adult patients with disabilities and caregivers, and it decreases the trust in our system, and I would say our, generally in quality of care. So in sort of like my hat of how do you build a better system, it's developmentally appropriate young adult care, and how do we ensure that happens across all specialties and ancillary services, right? So like one of my patients had to go to a scan, but somebody said, well, we don't take care of 40-pound patients. And so had to get transferred to the main hospital. But it was and also she wanted her mom there for support, and they wouldn't allow her to. Like, it's stuff like that still happens even within my system. And just lots of anecdotes of, again, I would fall into the developmentally appropriate care that I wish I can institutionalize, better. And I think the work is being done. And at the same time, we haven't gotten there yet.
One of the things that you talked about was time. And so I was just wondering, for when you're seeing a new patient transferring over to you, how much time do you get, and how much time would you like? And then also, in most systems, you're RVU based, and the more time you spend on someone means the system and you are making less money. So how do you make it financially viable?
Yeah, I bill by time. So far, my RVUs have been pretty good. So I use those 99215 codes for a new patient visit. And then I use the G codes as well. I typically have for a new patient, it's a 40-minute slot. And then I am allowed we got 2X. So anybody with developmental disabilities or multiple subspecialties, I book for 40 minutes regardless. And I do it more frequently. And actually that makes sense because God only knows like how many, like there's always something that breaks. I have one patient like, oh, my pump just broke. Oh, my wheelchair brake just broke. Like every, meeting, it's like, what DME order do I need to put in today? Right. Oh, my G2, anyway. So, ensuring a standard frequency so I don't have disasters coming. The billing by time and the modifiers is what I do. Now, for a new patient, I also bill the time I do the chart review. So anything, for us, we basically do a lot of time billing, and that has worked in with our RVU system.
Hi, Dr. Okamura. Thank you so much for what you've shared so far. I kind of wanted to go back to the last question that was asked, which is what keeps you up at night. And as a third-year medical student, even I have seen those patients who come into the pediatrics hospital who are well into their 20s dealing with these complex medical conditions. In your perspective, do you think there's a space for that disaster planning? How do we prepare for this patient to go to the hospital if that's what it comes to? And what are areas for growth that you see within that specific aspect?
Absolutely. I mean, those are kind of active conversations that we have here. I had one patient that went to the emergency department and they just didn't have the right size chest tube for them in the adult ED. And they were like called Benioff Children's Hospital. The mom was listening in and, was horrified. And it's like, how do we equip the adult hospital to ensure that all of the equipment especially for our our patients who have genetic disorders, and then, again, as we start transferring, more, or do we change our PED system that we take older patients because of the size issue, right? These are existential questions because it's no right. It depends. You got to do it, right? So if you are I say 40 because that's kind of like that threshold, right? Because, 60, 70 pounds is okay, but underneath that, then it's really kind of pediatric size. What do you do about that pediatric size patient? Is it about development, right, and age only, or is it about the tools that you use? And if it's about the tools that you use, someone's got to be equipped. Kind of like that 50-year-old in the reverse lead EKG. I'm like, right? I just need a standard 12 lead for an adult. Right? That's not appropriate. We have to give a standard of care and being able to fix that and making sure that our system can do that effectively.
Thanks, Maggie. This is really great to hear. My question is what about all the other adolescents who don't have complex chronic conditions, and what parts of this translate? And I have either, they're undiagnosed when they're adolescents or they haven't developed their condition yet, but they should probably be seen before they turn 40. I have so many, just one example, I have a 19-year-old who had acute sensorineural hearing loss and just hoped it would go away and didn't present for a month, and she could have had high-dose steroids, and now she's lost almost all of her hearing, and she just wasn't equipped to recognize and know what to do in that situation.
So I would argue that all patients still get the understanding and the policy, and also to recognize that primary care and how to be an adult consumer of healthcare, right? That's kind of the transition part. Why do you go see the doctor? It's not when you're sick, right? We always think, you go to the doctor when you're sick. Actually, no, you as standard of care should be seen at least every 2 to 3 years. You check in with your provider. You make sure that you have your good annual screening and stuff. Why? Because we want to keep you healthy. We will make sure that you're doing well. So it's not about scaring people, right? Because we also know that research showed that we can't scare teenagers. Well, kind of, but it's different. But really trying to make sure that we have this mindset of, I want to take care of myself. And yes, we focus a lot on the people with, complex chronic conditions and diseases, because if we lose care, they can do very poorly rapidly. But to your point about your patient, having regular care and having the freedom to chat, like we now have, many of us have electronic medical records, or even if it's a phone call, again, for that rule, so I'd say, is this right? I just lost my hearing, check in. If it doesn't feel right to you, just let us know. And then, for us, we'll be like, oh my God, get in now, versus, oh no, just take a Tylenol. You're fine. Call you in the morning. And having, that's another skill set, right? Talking and advocating for yourself. Those are all sort of like that transition readiness about being an adult consumer and advocating.
So I just want to say this is an amazing topic. Thank you so much for it. Something that actually just like made me just think about something that I'm probably missing is the difference between the transition versus the transfer, because I'm a primary care med peds doc. So sometimes I take for granted the fact that my patients will stay with me, as opposed to someone who is exclusively a pediatrician versus exclusively an internist. So in these kind of specific cases for us who are like med peds, but also like for family medicine or anyone who's seeing a broader age group, what are some things that we should potentially pay more focus on when we're not worrying as much about that, like, hey, this is the time where I can no longer see them?
Mm-hmm. Well, and I think, alluding to Dr. Aaron's comment on just young adult is greater autonomy in their healthcare, right? So you're kind of grooming that person to, I'm sure in your panel, you have parents who do everything and parents who step back, maybe should be involved. And for each patient that you have, some people will use there's like the checklist, like the track, for example, right? I don't use that one in my practice per se, but other people do. It depends on how you want to use it and integrate. Like, can you do your own refills? Are you calling your appointments? And making sure that they reach out to you. So for me, for my 18 to 19-year-olds, for example, I'm like, you write to me. And I encourage that. Thanks for reaching out. Pat them on the back for, communicating rather than their parent, right? So you can do that. And I'm sure you're probably transferring their care somewhere. And, again, the family involvement, most of the time I will have the parent out in the waiting room talking to the youth. And I'm like, hey, should we bring the parent back or not? Or I'll have everything in the after visit summary there. It just depends on the family dynamic. And again, where that patient is at in terms of their self-management. But again, it's a slow acquisition, right? Before they're just kind of ready to fly on their own.
Well, Maggie, thank you so much for spending time with us today here at this AMP session. I just want to ask before we go, do you have any last minute take home points you want everyone to know?
Well, I think that in terms of transitioning, there's so many ways to do it, right? You're going to look at resources. There's a lot of things in your own local communities and state. The only wrong thing is to do nothing, right? Whatever you do, even if it's at 12, by the way, I'm only going to take you to 18 and just leave it. It's still better than saying nothing. Right? The families will appreciate it. It'll be the talk, even if they're frightened, they're like, I know you said it, but at least it's a conduit. And so I just encourage that. I know it can be busy, in your practices, but at least to take a little bit of time to acknowledge, hey, you're going off to high school or your college. Oh, have you thought, with college, have you thought about how you're going to do your adult care? Right? Like it's things like that can start off that conversation. And I think it's a good thing because otherwise your patients will not bring it up, right? It'll be up to you at the end of the day.
Well, I think that's great. Thank you so much. I appreciate your time with us.
Oh, we always ask one last thing. Is there anything you'd like to plug? Any websites, organizations, things that we should have our listeners check out? Anything along those lines?
So I mentioned the Got Transition website there. They do a lot. Family Voices also had initiative. If you go on their website, they do a lot of family supports nationally. I also am part of the Healthcare Transition Research Consortium, that is online, and we have a national conference that, about transitions of care. So you can always check that out as well. Yeah.
Perfect. Thank you. Thank you so much. So this has been another episode of the Cribsiders.
It's for the kids.
Get show notes on our website at www.thecribsiders.com. And we're committed to providing you with high-value practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts, or contact us at thecribsiders@gmail.com. Special thanks to AMP for hosting us and our wonderful social media team, which is mostly Denise Cruz and Blue Sky on Instagram, and I've been Sam Mazer.
And this has been Chris the Chi-Man Chi. Thank you.